Okay, and this brings us to lesson 3, or our third CTG, to analyze and to interpret. And again, like all the previous ones, I really hope you enjoy it, and I really hope that you learn something new. Now here in front of you is the CTG number 3 that we need to analyze and interpret. And first of all, like with all the other previous two, we start with the baseline. Here you can see the red lines that I've drawn here to indicate the baseline, and we've said that we determine the baseline between periodic changes. So that would give us an average baseline for this pattern here, and you can see it's just above and on 160 beats per minute here. If we look at the variability, here we can still see some variability, and it might be more than 5 beats per minute, and the same here. But then here you see the variability almost disappeared. It's almost straight lines on these areas here. So again, we sit with a variability of less than 5 beats per minute. And then there are quite a few decelerations. With almost with every contraction there is a deceleration, and we will again discuss the decelerations in more detail on the next slide. If we look at the contractions, the rate of the speed of the paper is 1 centimeter per minute. So here we have a column of numbers, and here, so in between there are about 4 contractions per 10 minutes, and in between here is another 4 contractions more or less per 10 minutes. So here we look at the decelerations in more detail, and like on the previous slides, we have said that we look that there are 4 characteristics or 4 aspects that we look at when we look at the decelerations. So first of all, we've said we look at the relationship of the decelerations to the contractions. We look at how long these decelerations are, how deep they are, the amplitude, how many beats per minute they decelerate, and we also look at how quickly the fetal heart rate recovers and go back to normal. And that's basically the most important things. Oh, and the form of the decelerations. We look at the form of the decelerations, whether they are uniform, whether they look similar, whether they all look different, etc. So now if we look at these aspects on this graph, if we look at the relationship of the decelerations with the contractions, we see there's a deceleration just after the peak of the contraction. That deceleration is just after the peak of the contraction. That one as well. And then we have a little contraction there with a small little deceleration. And this deceleration is after the contraction. That little one as well. And all of these similar. If we look at the form of the decelerations, they're very similar in form. They're fairly uniform. The reason why these are being a little bit different is because of there are these small contractions in between, and the same here. But here they are a little bit not uniform. Here they differ a lot in their form. So we also need to see a little bit more about this CTG on to see what's going on here after this part of the CTG. So, and then we see that these contractions are decelerations are quite long. That one is about 2 minutes long. That one is almost 3 minutes long. And they are, if we look at how much they decelerate, here we've said is about 160 beats per minute, and it goes down to about it looks almost 100, just below 100 beats per minute. So there are more than 60 beats per minute. So we sit here with, I would say in this case, again, variable decelerations, very long decelerations, longer than 60 minutes, and they are deeper than 60 beats per minute. So we have quite abnormal variable deceleration. If we look at the classification according to the figure guidelines between normal and suspicious and pathological, Our heart rate is suspicious because our heart rate is not normal. It's not between 110 and 160 beats per minute. It's above 160 beats per minute, so it will fall in the suspicious column. Also, reduced variability makes it pathologically like the previous one as well. And now previously we didn't have in the second CTG we didn't have decelerations with every contraction or more than 50% of the contractions. In this case, we have decelerations with all the contractions, so we have decelerations with more than 50% of the decelerations, and they are prolonged, they are longer. They're not 5 minutes or 3 minutes long, but there is one that's almost 3 minutes long. So we sit with, according to the figure guidelines, with the pathological CTG graph here. So we need immediate action with that. If we look at this graph according to the NICE guidelines, we see again that we are not falling into the normal category because our baseline is not normal and our variability is also not normal. We again fall here in the non-reassuring column with our baseline because it's 160 and more, and we also see that our variability is less than 5 beats per minute, so that makes it falling here in the non-reassuring column. If we look at the variable decelerations, we see here that we sit with decelerations that are more than longer and deeper, going deeper than 60 beats per minute, and they are longer than 60 seconds long. And they all, like with our previous graph, we said they should be there for about up to 30 minutes. Our graph is not long enough to determine that, but if I'm sure, almost sure, if it was 30 minutes longer, we would have the same pattern. But then we also see that these decelerations are with more than 50% of the contractions. So if it's variable decelerations, it would definitely fall in here. If it's late decelerations, it would also fall in here because it's present for up to 30 minutes and it's with more than 50% of the contractions. And then depending on what happens after we have started with intrauterine resuscitation, if this does not improve or recover, we might end up with a pathological. Now, if we answer these questions about whether it's gradually evolving or not, the hypoxia, and we definitely have hypoxia here because we have definitely reduced variability. We have tachycardia, which is almost a sign of hypoxia as well. We have either late or longer than 60 seconds variable decelerations. So again, we have here a gradually evolving hypoxia. Again, we can't only do observational management. We can't just put the patient on a CTG, continuous CTG, and wait to see what's going to happen. We have to act actively and start with intrauterine resuscitation measures. And then, like in the previous slides, according to the figure guidelines, if we want to manage a suspicious trace, we do these measures, but according to our figure guidelines, we have here a pathological trace. So we have to start with resuscitative measures immediately while we are making a preparation for delivery. And if there's no improvement in the fetal heart rate, then definitely the delivery should take place, either by a cesarean section or expedite delivery if the patient is fully dilated. So we definitely have to start with in utero resuscitation, and we do it according to the maternal guidelines as we have said on the previous slide. So in this case, we will definitely do a vaginal examination because we have serious variable decelerations here. And we have to exclude a cord prolapse because that, as we said, mostly in variable decelerations, it's been caused by cord compression. So in this case, it might be a prolapse of the cord, so we need to exclude that. We need to reposition the mother onto a left or a right side to improve the blood flow to the uterus and specifically to the placenta. We might decide to give oxygen, and we have said in the previous slides that that's quite a controversial issue. And if we do give it, we only give 6 liters per minute via face mask for 20 to 30 minutes, and we see whether the condition improves. If the condition improves, we can stop with the oxygen. If the condition does not improve, we can stop with the oxygen anyway as well, because then it will not improve after 20 to 30 minutes. We improve the blood flow to the placenta by giving the mother intravenous bolus of ringus lactate, and the continuous IV infusion of ringus lactate, depending on whether the woman is hypertensive or not. And then we try and improve the placental perfusion by stopping oxytocin or prostaglandin administration if it is being administered. And then we can also, while the patient is waiting for cesarean section, stop the contractions by giving tocolysis and make also again improve the blood circulation to the placenta while there are fewer or less stronger contractions. And obviously, like in the previous slides, we also need to explain the condition to the mother. And then again, we came to the end of this lesson 3 and CTG 3 and the interpretation of CTG 3. And like with the previous ones, I really hope that you have learned something. I really hope that you have enjoyed it. And I'll see you at another lesson again.